Hello, thanks for inviting me to speak for a few moments on friends and family. I'm the only part of this conference that's going to be talking on something not related to dementia, so I feel a bit out of place really. So one thing I found really interesting though, before we talk about friends and family, is seeing lots of different people from all over different parts of the country. And the one humbling thing for me just sitting there listening is that how many of you are not just laminating your values, you're living them. And I find that really encouraging to listen to, so thank you. So thank you for live your values, don't laminate them. It's yes. Right, so as you've heard, my name's Paul Morris. I'm the lead nurse at Ipswich Hospital Emergency Department, and you'll see another theme of the conference of another lone unit, courtesy of my dementia. I'm going to call it the wrong thing, I know, so apologies. So this is our unit. This sits in the front of our emergency department. It sits just by the front door. We all know that the Friends and Family Test was created with a requirement that we all had to submit data, and back in the 1st of April 2015 that changed. So did you all have these little token boxes where you used to put the little tokens that dropped in, and we asked the same question and they were okay and it seemed to sort of work, but the response rate was quite low. So this made a massive challenge with us. So we're probably very similar to all of you, where you've tried different things. So we tried QR codes, which are those like out of focus, I'm not very technical, so those out of focus square boxes that you can scan with your phone, that would take you to the link of the questionnaire. We tried giving business cards to everyone on A&E, so as you booked in, we gave you a business card and then you could tick the response you felt at the end of it, but people went home with them. We tried texting a number on a scrolling number from on the TV that tells you the waiting time. All of these things didn't really have a massive impact for us. So it ranged somewhere between 3.5% and at best 9.1% the 3 months pre the trial of this screen. So at very best it was 9.1. At the same time we were trialling a different method of triage. So we were trying to catch people within the first 10 steps of walking into an emergency department. We greeted you by a streaming nurse and then focused where you were going from that point. The byproduct of that is that the nurse was there, so as you walked out, if you'd like to leave your feedback. So that was proactively trying to get feedback from our patients. In the 2-week trial period of using this unit, it had a return rate just on its own, just sitting by the exit of our miners entrance, of 14% just on its own. So we had an increase there of 5%, which was quite impressive. So this is our unit. This is us trying streaming. Alex will be very pleased that he's managed to get into my presentation. That's our triage nurse. And what we're doing there, so you're greeted by a streaming nurse with a receptionist who would stream you to the most appropriate area for you to have your care. At the same time, we were on your way out, they'd ask you for feedback and give you the opportunity to use the screen, as you can see on the screen. Bearing in mind that we've only got the one lone unit, this was sat at the front of our A&E department, so it was only our minor people who walked in from off the street effectively. So from the 1st of November to December, we had basically a total of 926 responses over 61 days, so an average of 15.8%. The trial is finished with our streaming, and what's happened here is some of the breakdown of these figures. So we returned a rate of 15.8%. So it tells us likely, unlikely, extremely unlikely, neither here nor there. The one benefit was for us is that we've seen some really good presentations about data, but we've also seen some good presentations with data and context, which is really, really important. So the rounded results came to about 13% extremely unlikely, 5% was unlikely, 4% was neither likely or unlikely, 14% was likely, 56% was extremely likely, and then 8% was don't know. So for me as a lead nurse, I was particularly interested in the unlikely and the extremely unlikely, because these are going to tell me where my problems are and where I should need to focus. So the most recent data, bearing in mind our streaming trial is finished, so now we literally do have just a TV screen effectively with our smiley faces there on the exit. The benefit of this screen is that as you tap however you want to rate our service, it then produces a screen where you can give accurate feedback. So actually, why was it you put your comment and how can we improve? And there's an opportunity there that they can then leave their contact details if they want, or they can just put their comment, and I'm going to show you a few of their comments. So return rate of just 10% with just one screen, and that's a return of 15.2 if you look at the total numbers in our departments. So about 2/3 of our department walk in, and 1/3 of them come from the back door. These are some of our comments. So I'll point you to some of, so the streaming nurse is miserable. So that's quite an interesting comment. So you're going to have some good comments, you're going to have some bad comments. These are only available to the manager, and I can email these. So my day starts as I walk into the department, I walk past the screen, I go into the manager's page, I look at the feedbacks for the past 24 hours. In A&E we tend to have a staff room, so the staff are congregating, ready to start their day. I will then give them feedback of what our patient said about us yesterday. We'll talk about day techs, risks, complaints, and it's 5 minutes before they have their handover. So it's very live data. It's brilliant because it's date and time stamped, so actually I know that who was the triage nurse on this day when somebody said you were quite miserable. Is this a one-off? Was it somebody's opinion or a perception, or is this a pattern that we can start seeing emerging? It can be, doctors, is it about praise also? Does it mean I need to give really good feedback to somebody to say, this is how you came across to several patients? And there are days where we have said nurse was brilliant, friendly, smiling, warm, effective with my pain relief, or it can be negative, like they were miserable or not approachable. So you can actually start to pick up themes and give both positive and negatives for your staff. So the benefit, as I've touched on, it's easy to use. That's why I think there's been such a success. You touch a button. If you want to leave a comment, you can leave a comment. If you don't want to leave a comment, you don't have to. From a manager's point of view, I can press email to me and it sends it all across in an Excel spreadsheet, so I can send it to all of the relevant people to actually feed that information back and report to all our relevant reporting structures. It dates and timestamps all of these comments, which is really important for me because it's rich data. So it's not just about what you've rated the service as or your experience as. It's actually why was it, and it can be both positive and negative. So that date and timestamp is really key to me because also it tells us about what is the service like out of hours, in hours, daytime, nighttime, weekend, weekday. So that was a really important thing. This all came about after a conversation when we were seeing my dementia screen, and it was about the feedback that we talked about, the smiley face, and it was looking at that and saying, we really like this, but could it also do this? And that's where that conversation has come from. So mine is really a very brief presentation of talking about how we have captured friends and family and the response rate it happens. So looking at so far up to yesterday our data, our response rate currently with a member of staff on returning to duty, so they're going around doing the paper questionnaires, is now at 16.9% for the month of February. That's just come out. So it does have a dramatic impact. Does anyone have any questions, please?
Thank you. How does 16.1% compare with the friends and family returns nationwide?
Nationwide, I think it's quite a common problem, especially in emergency departments. So it seems, I don't know the exact figure, but those within our region have been struggling somewhere to around about 9% is as good as we can get it seems. If you've got increased people on, return to practice, sometimes that can go up, but it seems to be, you're quite happy if you're getting those sort of levels. So it's definitely had a big impact for us, and for something that is just sitting by our door, effectively, it's not having, and the data it's producing is most other systems you're relying on, maybe people aren't writing comments, maybe there's a language barrier, there's lots of different reasons for that, so it's been really useful.
Hi, Colette Cunningham, Divisional General Manager for Medicine. So nationally we should achieve 20% for our FFT. In Bradford we're lucky for achieving 2%. So I'm really pleased to hear your presentation. We had the boxes with the tokens. The kids used to love taking the tokens home for some unknown reason. So that's really promising. 16% is actually really good.
And I think it's something that's quite a challenge with lots of different people because you want feedback, and it's that negative feedback which is sometimes really important because it will maybe give you how they've perceived that interaction behind a closed door. And obviously when a lead is around or people know they're being observed, sometimes behaviour is different, so it's important. But yeah.
Hi, I mentioned earlier about us collaborating and sharing information. I wondered how compatible your friends and family IT is with the actual units, because surely there's an opportunity while relatives are actively engaged with patients to get that real-time feedback.
It is compatible. It's built on the same system as the DRTS. The problem is, if you're actually getting people to do friends and family, you're taking it away from people that may need DRTS. That's why we do standalone. And ideally, they're actually separate at the exit to a ward or something like that. What we're actually doing with Paul's actually purchased some units now, and we're also providing him with a tablet version, which again will be independent specifically for the friends and family survey. So it doesn't have a dual purpose. I think that's the thing, because what you don't want to do is not be able to capture 20 friends and family responses because somebody's having a session on DRTS. They're both as important as each other. But the tablet obviously can go to the bedside. So particularly in Paul's environment in ED, it is, as Paul says, there's a lot of people that actually don't get up and walk back out of the door. They may go up onto the wards. They're not being captured at the moment. And it can actually go into the bays and into the department and actually be utilised an awful lot more. So we're very confident that 16% will increase significantly. And it's just, it's like Paul said, I think it's more about the usability of the data as opposed to the stats, really. The stats, as with most of these things in the NHS, the stats and the targets are there to achieve, and there's funding attached to it, and there's lots of different kudos attached to reaching your targets. But actually, it's the usability of the data that's the important thing. It gives you an opportunity to affect change where change is needed and praise where praise is needed, and all of those kind of things. So
we're now about to take delivery of the other units. So we're going to have one by the front door as you walk in and out, one in the paediatric area. We're going to put one on, we have one corridor which basically links our department to the rest of the hospital. So there'll be one there, so we'll be then encouraging our nurses to stop, give the patients an opportunity, because that's one group of patients we don't really get much feedback from, are the ones we admit, because there tends to be maybe a bit sicker, or the ones that they don't go past the screen. So actually there'll be nowhere in the department other than our resus room that you will miss the opportunity to give feedback in that sort of format. So.